you got your flu shot this year?
I did.
I did not.
I am upright.
Yeah, so cute.
And you are not.
I'm not. I'm not. I'm Lloyd Finks, MD.
And I'm pharmacist Dr. Shannon Finks.
Welcome to the ZUP podcast. Here we take an intentionally different approach to the practice of medicine.
That's why our podcast is all about answering your burning questions and challenging the status quo in the healthcare industry.
Right. All while making medical information digestible and accessible for everyone. You ready to stir the pot?
Let's get cooking.
Hi, pal.
Hey, how you holding up?
Oh, I'm broke, Ken. This is, well, you know what I thought we might do? Let's start off with some medical news real quick, all right? Real quick. Cool. Number one, as of today, Robert F. Kennedy Jr. looks like he has been approved for his new position.
Correct.
All right, so that's something to think about. Number two, worst flu season in the past 15 years.
Yeah, since 2006, I believe. So almost 20 years, yeah.
Almost 20 years, and you are seeing the result of it right now.
Yeah, I'm sorry. You feeling any better?
Thank you for asking. We're going to leave it right there. No, I think it's a good lesson. You got your flu shot this year?
I did.
I did not.
I am upright.
Yeah, it's so cute.
And you are not.
I'm not. I'm not. I didn't get a flu shot this year. I have my own reasons for it. All of them stupid, obviously.
No, it is everyone's right to make a personal decision, but it is a good idea to talk to your provider, your pharmacist, or your doctor about how to protect yourself going into.
Which I apparently have several, and I ignored.
Well,
so, yeah, anyway.
Your choice.
But third bit of information today, lots of times at ZUP we'll get people in with red eyes, conjunctivitis, right?
Right.
And routinely, if they have one eye that's reddened and obviously has a conjunctivitis, pink eye, as we call it, then we go ahead and say, yeah, it's probably viral, right? And both red eyes, all right, we typically say that's probably allergic here in Memphis, second worst allergies in the whole country.
Sure.
We say that. Did you see the news about bird flu?
I sure did.
Yeah.
Presenting symptom.
Yes. Yeah.
Most common presenting symptom.
The most common presenting symptom right now for bird flu is conjunctivitis, particularly bilateral conjunctivitis, bilateral pink eye. And so we've got our providers tuned up right now to take a second look at somebody who's presenting with red eyes on both sides.
Yeah.
So terrifying. Right?
A little bit.
Yeah.
For sure.
Yeah. RFK, flu, bird flu. Choose your terrifying news.
Well, I have no terrifying news. I could say, though, that Heart Month is ongoing and tomorrow is Valentine's Day. So I thought that we might talk a little bit about...
Terrifying. Yeah.
I thought we might talk a little bit about the heart and just kind of focus maybe on, we're February 2025, maybe talk about some trends or tips to reduce your risk of having a heart event.
And when you say heart event, are you...
Heart event.
Heart, not hard.
Right.
Heart event. But it's not just heart, is it?
No. No. Actually, coronary heart disease comprises 50% of what's called cardiovascular disease. Okay. And that cardiovascular disease is the number one killer of all Americans, both in men and women. Yeah. And it comprises not only heart disease, but cerebrovascular disease, so people who have strokes, peripheral arterial disease, people who have a symptom of like intermittent claudication. They can't walk upstairs without their legs cramping. They have reduced blood flow in their legs. And then, of course, abdominal aortic aneurysm, those types of illnesses that contribute to the number one cause of death.
So a cautionary tale,
sure,
right? Before we start on this, because we talk a lot about one of the difficulties in addressing coronary artery disease, coronary heart disease, diabetes, hypertension. These are not typically diseases that have symptoms until it's too late, right? And so my oldest friend, guy that I have grown up sailing with since we were 17 years of age, called me the other day and he said, hey, strangest thing happened. We were watching TV and I felt this ache in my left arm. And you know how you hold up your arm? And I said, no, I really don't hold up my arm that often. He says, well, I held up my arm and I couldn't hold it up. It kept flopping down. And he said, what do you think I should do? And I thought, well, this one is not that difficult.
And I hope you sent him for evaluation.
We did, and he in fact had a stroke. You can call them a mini stroke, a TIA, because his symptoms did resolve very rapidly.
He's lucky.
He's so lucky, but he turned out to have carotid artery disease,
Yes.
two sets of arteries that feed the brain, and wound up getting something called a carotid endarterectomy, where they scrape out the goop. But he's very lucky.
Super lucky.
He's very lucky because he had sufficient warning signs without persistent symptoms that he could go in and have something done about this.
Well, you talk about warning signs, and that's actually great because that leads into maybe my first tip for understanding your risk for heart disease, and that is know your numbers. And he knew that he had high cholesterol, and he had tried medicine but had side effects and just kind of gave up on the process because he didn't have a provider that really pushed and got him on medicine that lowered his cholesterol to the point that, is generally recommended that would reduce his risk. And I hate that for him. We tried a couple of things in talking with him, but we're not his providers. He lives in another state, so we could only do what we could do.
Yeah.
But I think if there's anyone out there listening that wants to know rule number one, it's always know your numbers. And those numbers are not only your total cholesterol, but your LDL, your HDL, your non-HDL cholesterol, your triglycerides. And if you have advanced lipid testing, ask for ApoB or apolipoprotein B. Ask for lipoprotein(a), especially if you have a
Slow down on that
family
one.
history.
Lipoprotein(a).
Little a.
Yeah,
right.
You guys say that really fast, and some of us go, what?
Yeah. Well, this is a lipid test that is very interesting right now. It's becoming in favor of testing, especially when someone has a really high LDL or someone who has a premature family history. What we've learned about that lipoprotein is that it does not only cause the atherosclerotic process, it's cholesterol that lays down in the arteries, but it's also prothrombotic, meaning it's likely to cause a clot to form. And so you can't feel high cholesterol. You can't feel that you have high ApoB or high lipoprotein(a). These are risk markers that everyone should know.
What are some of the other risk factors involved in the proliferation of atherosclerotic?
You can't even say it.
I can't, and I need a nap.
It's
Atherosclerotic disease.
Yeah. So I love to tell patients that not only do I love to tell patients this statement, but I like to tell patients the truth.
Okay.
And that is half of all MIs occur in patients with normal lipids. And so when I say lipids, I mean cholesterol. And so it's not only can I get my cholesterol down, but even if we do that, there's still residual risk. And it's very important for your provider to assess for inflammatory markers, inflammation. We hear that all the time. Oh, I'm inflamed, or I have inflammatory markers. But inflammation is the trigger that starts the vascular damage, if you will, in this process. And there are multiple triggers, but chronic inflammation is like the match that just keeps that process going on. And if we know your cholesterol levels and we also know your inflammatory markers, we can be more aggressive in people who need that more aggressive push, like your friend Mark.
Yeah. Whose name I wasn't going to mention.
Oh,
but
sorry,
that's
Mark.
Perfectly okay. Mark. So you say know your numbers.
Yeah.
All right. But 50% of people who have these vascular events have normal cholesterol.
Right.
Right. Well, first of all, let's eliminate some other risk factors or include some other risk factors. Hypertension.
Right.
High blood pressure.
Know your numbers.
Know your numbers.
You want to
right?
be less than 130 over 80 and ideally less than 120 over 80.
Okay.
So knowing where you are and
so if somebody's 135 over 85, is that a problem?
well, it starts to become one, and it depends on your underlying underlying risk. We typically start medication in people who are higher at risk once they're above 130/80.
Okay.
We might have a little bit of wiggle room in patients who have a lower risk,
Right.
and that's another thing that you should know. Your provider should be calculating an ASCVD risk score.
All right, slow down. A what?
An ASCVD risk score. And
Okay.
that's a calculation that predicts your likelihood of having a heart attack or a stroke over the next 10 years.
Okay.
And this is a vetted, if you will, equation that is endorsed by the American Heart Association.
So let's say that somebody has hypertension, high blood pressure is being treated for that. Diabetes would be included in that list?
Yes, diabetes would certainly be included
Yeah.
in that list. Someone who has diabetes is 2 to 4 times more likely to die of a heart event than someone who looks exactly like them, their age, their weight, without diabetes. And so glucose abnormalities are contributory in a very progressive way.
How important is a low-fat diet? And I'm thinking of somebody in our family who lived the last part of her life eating no fat.
Right.
Right?
Well, you're talking about my mom,
Well,
and
I am.
I'll tell that
God
story.
bless her.
I know.
Yeah.
We lost her last year, but I mean, she was one of those patients that took every word that her physician said as gospel, and she had a little high cholesterol. She also had high lipoprotein (a), and that was probably what was her contributing factor. But she was told, well, eat a low-fat diet to bring down your cholesterol, because she did not want to be on cholesterol medicine. And most people only get about 5 to 7% reductions in lipoproteins because of diet alone. But my goodness, my mom, she gave it the good old try, and she got more than 10% because she was absolutely rigid about her diet. But that is, low-fat diets are very hard to adhere to.
Yeah.
And
Yeah.
they are going to contribute to cholesterol reduction, but that's not the only thing that you can do. Here's another tip, though, since you brought up diet, everyone should focus on soluble and insoluble fiber. And those are plant foods that kind of slow cholesterol absorption, and it also reduces what we refer to as the glycemic load that you get from eating food.
Simple sugars. Primarily.
Right.
Yeah.
And so not only with fiber are you slowing down cholesterol absorption, so you're getting a cholesterol reduction, but you're also slowing down perhaps the insulin resistance that leads to diabetes, because your sugar isn't spiking as much. Men, Lloyd, you should be counting your fiber. Men should get 30 grams a day.
This from the woman who's never met a hamburger she didn't like.
Oh,
right?
I love hamburgers,
I
but
know.
I'm going to have lettuce, tomato. I'm going to add all the fiber onto it that I could possibly add. And French fries probably don't count, even though they're a good vegetable.
Right, French fries don't count.
No, they don't count.
Oh, so it doesn't count as fiber or a vegetable.
Not when you fry it.
Yeah.
No, not like that. But women should get about 25 grams of fiber. So that's actually been shown to reduce heart disease. And so those are our targets for people to shoot for. It's a healthy.
So I eat virtually a meatless diet. I'm not a big fan of meat, and my normal diet, it consists of a lot of high fiber. I eat a lot of whole grain breads,
you do.
Natural breads, a lot of whole grains, things like that. So how does it feel to live with somebody who is going to live forever? I know you're very optimistic about your future.
I'm not ready to announce that we can live forever, nor do I think we want to live forever.
So speaking of living forever, and in the radio business, this is called a segue. But speaking of living forever, there's a lot of stuff going on in the news right now about of course, the GLP-1s, right? But also their benefits in weight loss, of course. That seems to be the primary reason most people take them. But obesity and overweight itself is an independent risk factor for vascular disease.
It is.
Right? Just by itself.
And if you come into ZUP and you're a patient at ZUP, we're going to actually get a waist circumference on you if you are one of our cardiometabolic patients. And although that may sound disgusting to many of you, it is a vital sign, if you will. And what we know about the waist circumference is that it gives us an idea of how much visceral adiposity, when I say that, I'm talking about the fat that surrounds the organs in our midsection, a very important part of our bodies, housing so many different organs. But if that fat is a burden or a very large content, what we used to think is it was just cosmetic, but what we understand now is that fat tissue is one of the, if not the, most highly active
metabolically active, yes,
endocrine organs in the body. And so we don't need to think about just a belt size, if you will, or a clothes size as something that is simply cosmetic. What we understand is that the larger the waist circumference, the more what we call adipokines, which are cytokines. They're chemical messengers that are released from the fat tissue.
Root word adipose.
Adipose tissue, fat tissue. And those aren't good, friendly chemical messengers. Yeah. What they're telling the body to do, they're kicking out more inflammation, they're causing more vascular damage, they're causing more thrombotic states. There's so many different negative effects of those adipokines. And so for us, adds up, waist circumference is a huge, important vital sign that we look for. We want that less than 40 inches in males and less than 35 inches in females. And also ethnicity matters because, for example, like Asian individuals are generally smaller than American individuals. And so their cutoffs are a little bit lower than the traditional or typical American
Is it different for Southern men? No, the reason I'm asking that, the reason I'm asking, no, see, you're laughing at me, and I'm actually getting to something here. Because with Southern men, as you know, you can wear a size 32 jean, right? Yeah. And there's about 350 pounds of belly above that, right?
So when we take your waist circumference, we're going to use the recommended position that the National Institutes of Health suggest, and it is not your belt size. It is in your midsection, and it's
I'm much more svelte when I lie backwards.
Yes. Aren't we all? But it gives us a target to shoot for. So when we assess someone for cardiovascular risk, that's a component.
I want to revisit one point about these risk factors. And we've talked about hypertension, we've talked about diabetes, we've talked about high-fat diets, low-fat diets. What about genetics? I mean, does that, some folks, you watch them eat and there's 3.5 pounds of steak in front of them and their cholesterol is absolutely perfect. Yeah. So what's going on there?
There's a couple of interesting genetic influences. Well, there's not just a couple, there are many. But I'll speak to genetic influences for cholesterol first, and then maybe we'll talk about some others, and if we have time. But
I've got time.
I'm glad you do. So it's interesting. Most of humans are typical absorbers of cholesterol, but there's about 15% of us that are hyper absorbers. So there are certain medicines that block cholesterol absorption from the gut. And if we know ahead of time that you're a hyper absorber, you're going to get a certain medicine to block some of that absorption from what you eat. So that's an interesting finding. Another is absolutely you can have genetic influences. There's a disease called familial hypercholesterolemia where you inherit 1 or 2 copies from your mom or your dad. And these patients typically have LDL, which is generally what the public knows and recognizes as the bad cholesterol. Their LDLs are in the 200s, 300s, and if you're homozygous, meaning you get 2 copies, one from your mom and one from your dad, you could have LDLs in the 400, 500 range. And these are typically patients that see their cardiologist very early in life because they've already had a stroke or a heart attack by the time they're 30. Not great outcomes. You can have a genetic influence over low HDL or low good cholesterol, if you will. And you can also have genetic influences on how well you may tolerate the most common drug that's used for dyslipidemia, and that's statins. So lots of genetic influences over how our labs look.
So in your perfect world, in your perfect, I'm sorry for cutting you off, but understanding that insurance rarely pays for a lot of this stuff. In this,
Actually, the genetic test is covered. I mean, you would have a copay,
right.
and that copay may be anywhere from, maybe $0 to $300, depending upon your insurance. But we use often a genetic test that looks for these cardiovascularly influenced genetics. And not only that, but obesity, as well as diabetes, as well as Alzheimer's disease. So we have a armamentarium of genetic tests now that are fairly affordable.
Okay. So, all right. So you answered my question. In your perfect world, if I were to come to you as my provider, would you just love to know my genetics before we even start?
Well, yes, I love to know genetics because it's fascinating to me. And I think genetics gives me a place to start. Before testing for absolutely everything, I can look at your genetic information and say, oh, well, you're predisposed to X, Y, or Z, and so I'm going to start here. Maybe there's a smaller window that we start. But genetics allows us to be very aggressive with prevention earlier in life, not waiting for symptoms, not waiting for a stroke to occur. I can be more preventative.
Proactive. Yeah, sure.
And unfortunately, our healthcare system is not, it's more reactive than proactive. Yeah. But that's where we are.
Yeah. One silly question.
Sure.
The continuous glucose monitoring has been a game changer for patients with diabetes, right? I mean, the ability to go ahead and wear a monitor that continuously monitors and now increasingly manages with the injection of insulin, right, a patient's glucose has been amazing for diabetics. But I'm hearing of non-diabetics monitoring their glucose. What is up with that?
It's a fabulous way to look at what you're eating and what is spiking your blood sugar. And we talked about that glycemic index and why fiber is so important. But when you understand what you're putting in and how that affects your unique blood glucose, you can really self-moderate. It's no different than having the Apple Fitness watch or app and knowing, okay, I'm going to get 10,000 steps today. You begin to eat and then understand, oh, that spikes my blood sugar very high and insulin kicks in and then I want to go take a nap. But if I eat this way instead, I am good to go all day long and I have much more energy and my cells are more healthy because of that, without the peaks and the valleys, if you will, of sugar highs and sugar lows.
So in review, hemoglobin A1C, which is what we monitor typically quarterly with our diabetic patients.
And in your non-diabetic, we're looking for pre-diabetic.
Well, we're looking for pre-diabetes, right? But in our diabetics, we're looking at their glucose over an average of about 90 days, right? Right. And that takes a look at the red blood cell and says, what has been my average glucose?
Right.
But that could be the result, an average could be a result of very low and very high.
Right.
And it's those very highs that precipitate the inflammatory response that begins the process of this vascular disease.
Sure.
So what you're telling me is there are non-diabetic patients who are wearing continuous glucose monitors. And I'm sure the insurance companies are paying for that.
Oh, no. I mean,
they got to be thousands of dollars.
No. You can purchase them cash without a prescription, and you can get them as low as around $100. Now, some of them are more expensive than others, but it's a fabulous way. I'll give you one example. Okay. So smoothies, everybody's so excited about smoothies in the morning, but if you just put berries in the smoothies, the minute you add more fruit and you mix that up, your blood sugar will spike actually higher. But if you combine that with flaxseed and with some fat in your protein yogurt, it blunts the response. But everyone is different. Like if you use raw sugar or if you use coconut sugar, or everyone's response to that glucose load will be different. And so it's very individualized. And I have friends who are in the healthcare industry and even including some cardiologists who are not diabetic who are wearing it to understand a little bit more. And it's great. It's great. It is a way to understand your unique risk and
How
do
fun.
something about it.
Yeah.
So we've actually talked about a lot of the tips that I would have said to someone if they asked me, what do I need to do to really be serious about thinking about my risk for heart disease? And that really is knowing your numbers and having a provider who will test for these lipid abnormalities, inflammatory markers, maybe adding genetics to the mix. Also eating more healthily, but getting those grams of fiber that we know help not only with cholesterol, but help with glucose control as well.
Well, we talked about pretty much everything. Your CAC score
Oh, yeah. No, that's an important one we haven't discussed yet. I get the question every day. I don't want to take this statin. What should I do? And if I had a crystal ball to say, you don't need this statin right now, why wouldn't I use that? And a CAC score is a coronary artery calcium score. It is an imaging study, if you will, that looks at calcium that's laid down in the coronary arteries. Calcium does not belong in the coronary arteries. So when you see calcium, you've got to be aggressive. Those patients with calcium already in their coronary arteries, we're going to start a statin. But the CAC score is relatively inexpensive, and it also can delay someone from starting a statin. So if your CAC score is 0, you can say no statin at this time in those that are borderline or intermediate risk. And I love giving that news to patients because those who really don't want to start taking a medicine for their cholesterol, we can do other lifestyle approaches. We can use some other supplements perhaps that reduce cholesterol, and they are just overjoyed sometimes when they hear that they don't have to take a prescription medicine for their cholesterol.
So the first, if you see a CAC score of 0, a coronary artery calcium score of 0, is it safe to assume that not only are the coronary arteries clear, but the carotid, I can't speak today, the carotid arteries of my friend Mark, are they clear also?
No, you need a separate test for that. You would need a carotid ultrasound to be sure.
Okay.
And that's why your friend, Mark,
whose name shall not be spoken.
Shall not be spoken, he would have needed that additional test to be sure.
So we hope you've enjoyed today's podcast. It is American Heart Month.
It is.
Is that correct?
It is. And don't forget, tomorrow's Valentine's Day.
And don't forget, tomorrow is Valentine's Day, and
you need to go
so
out and
hosed right now. But we appreciate you listening. We appreciate you watching. And remember, we're happy to help you with any of your questions. And maybe if you give us some suggestions, we'll be happy to talk about them in a future podcast.
Yeah. If you need us, or if you are in a situation where your provider is not aggressive enough in your mind in terms of prevention,
aggressive.
Give us a call. I mean, we're very proactive in cardiometabolic risk, and you're going to ask for a cardiometabolic assessment or a cardiometabolic screening, and you can call us at 901-701-7010.
Perfect. Till next time. Thanks so much.